I want to talk about the Supreme Court case that was heard last week, which is United States versus Skrmetti. And what I want to achieve in this podcast is talk to you a little bit about the medical perspective of that case. Now, if you want to hear the whole history of the case in great detail, there are lots of podcasts and articles out there that can tell you all that. Out of respective time, I'm going to give you a really, really brief summary of how it got to the Supreme Court, the arguments being made. Again, very, very brief. Lots of places you can go to listen to the full thing. But then I'm going to tell you where my questions, what I think needed clarification from a medical perspective, the thoughts I had listening to those arguments. And that's where I want to focus our time today. And I think if you listen to the end, you're going to hear some things that you probably did not know or did not consider. So stick with me. All right, so a little bit about this case and how it got to be there. Now, the states of Tennessee and Kentucky is where this begins, and each state individually put out their legislation voted on banning gender affirming care, all gender affirming care, medical and surgical, for anyone under the age of 18. That case got brought to the district courts, and the district courts decided to put an injunction to stop the ban, that medical treatment should keep going on the basis that it was sex-based discrimination and that it was removing parental rights as far as the rights of parents to make decisions with the healthcare providers on the care of their children. But the states, Tennessee and Kentucky, both decided to appeal it and took it to the Sixth Circuit Court of Appeals. And the Sixth Circuit Court saw these two cases as quite similar, basically the same, and put them together and heard the case. And what the circuit court decided, they just looked at it from the medical perspective, not the surgical, because the families and physicians that were suing about this ban only had medical care, not surgical care as far as gender affirming care. So it was only medical. So they only looked at the medical aspect of gender affirming care. And what the appellate court decided was they did not agree with the district court's decision. The appellate court decided the bans can stay in place. So the United States, along with these families, took it to the Supreme Court to ask the Supreme Court to answer the question whether this was sex-based discrimination. So what the plaintiffs were arguing, these families, as well as the United States was arguing to the Supreme Court, was that this was sex-based discrimination. Why? Because if a male child wanted testosterone to start puberty because of a delayed puberty, then they could get testosterone to start puberty. But if a female patient wanted testosterone to start puberty in alignment with them, with their identity, they couldn't have it. And so this is the sex-based discrimination that you were allowing it based on the sex of the patient. And so that was their argument. And what they asked the Supreme Court to do is to see it as sex-based discrimination and send it back to the appellate court to redecide under higher scrutiny. What the defense was saying, which was the state of Tennessee in this case, what the defense was saying is this is not sex-based discrimination. This is based on diagnoses. It is based on the difference of the diagnoses of whether it's precocious puberty, delayed puberty, or any other diagnoses, and gender dysphoria. So that is the premise of the case. And what the defense was saying was it doesn't matter if you're a transgender boy or a transgender girl, we say no to either one, so it's not sex-based discrimination. Now, here are my takes on the medical issues that were discussed, and I listened to the entire argument, 2.5 hours of arguments, which I highly recommend. But here are the takes I have. One of the arguments the defense had is a diagnostic difference. These are different diagnoses that we're talking about for the ones that we say, yes, you can use, and the ones we say, no, you can't use. But we in medicine often have different diagnoses and allow the same treatments because they're doing the same thing or similar things. So let me give you an example. Some of the anti-rejection medications used in organ transplants are also used in ulcerative colitis, not as a transplant, but as its disease form. And the goal of it in transplants, this medication is to prevent rejection so the organ can run and be used functionally. In ulcerative colitis, it is to decrease the chance of an ulcerative colitis flare. So they're different in what they are doing. They're different in diagnoses. Now, again, I guess the question I had when they were talking about different diagnoses, like at what level does this difference become important? Because at some level, both the transplant and the ulcerative colitis are asking the medication to calm down the immune system to either not reject or not create a flare up. But we use medication all the time with different diagnoses that have different purposes. In the case of gender affirming care, a medication, and remember, we've got two different ones we're talking about here. We're talking about puberty blockers. So, puberty blockers may be used for something like precocious puberty, meaning puberty that starts too early. You use the puberty blocker to stop puberty. For gender dysphoria, you use a puberty blocker to stop puberty. So in both cases, we're asking it to do the same thing. It's just a different diagnosis. And for estrogen and testosterone, one reason you might use it is for delayed puberty. So puberty that hasn't started yet, you use it for that. And in gender dysphoria, we use it for a puberty that hasn't started yet to get it started in alignment with their identity for both diagnoses. So, how much difference does it have to be? Because we often use medications for different diagnoses. But the other problem I heard in the defense when they were talking about this is they referred to using it for gender dysphoria as using it for psychological reasons, and any other reason is for, quote, deficiency. I think at a different time they used the language of biological reasons versus psychological reasons. And I just want to put a pause here because let's look at the diagnosis of precocious puberty. We use it for biological reasons, right? Puberty is starting, we want it to stop, but we also use it for psychological reasons. We use it for psychological reasons because there is an effect on the patient for going through puberty early. And in fact, if you read about the treatment of precocious puberty, you will read that it's also for parents' anxiety of their child developing too early. I would venture to guess that anxiety has to do with how their child may be treated or mistreated due to that early body development. But we do take psychological factors into account. And the same thing with delayed puberty. There are studies on patients with delayed puberty of the psychological effects of going through puberty much later than their peers. And that is one of the reasons that there is a treatment for delayed puberty. So, yes, there is a biological reason, but there is a psychological reason for these treatments. Just like for gender dysphoria, I would offer that not only is there a psychological reason that distress a patient may feel with their body not being in alignment with their identity, but there is also a biological component to that. And I don't have enough time in this podcast, and I hope to do one in the future about some of the knowledge we have of the differences in brain when it comes to gender, but there is a component in the brain, so there is a biological difference there as well. It is not a pathological problem, it is not a problem, but there is biological variation that is in effect here. All right. My next issue with some of the medical discussion here was there was a concern for the medical treatment. And some of the concerns that were brought up. One was that it's a new treatment. So I'm going to take these one at a time. A new treatment. My question I kept thinking is define new. How old does a medicine have to be to not be considered new? So let me give you an idea. Do we consider Ozempic new? So if you don't know what Ozempic is a semaglutide. It is originally used for diabetes, and it was approved in 2017. So it's about 7 years old. You probably more likely have heard it in the realm of weight loss. Is that new? Is that I don't know. Is 7 years new? Because when we look at puberty blockers, it's always, oh, it's so new. Well, it's been used for precocious puberty since 1980. So 44 years? But you're like, "Oh, no, no, that's different. That's precocious puberty. What about gender dysphoria?" In gender dysphoria, it's been used in adolescents in this country since about 1998. And if we're looking at the kids that go through a social transition and then start puberty blockers once puberty begins, that protocol began in this country around 2007 with Norman Spack in Boston. So even if we go with that latest data, 2007, 17 years. So again, I question, how long does a medication have to be around for it not to be considered new? There are tons of medications that are much younger than this. Lipid lowering medications, we could go on and on. I already mentioned Ozempic is younger than this. So what we keep using the word new, and I want us to define new, because if this is new, there are most of our medications are new. The other word often used is experimental. It's experimental, experimental. Now, in my world, something is experimental if it has not been FDA approved yet. And I'm going to talk about FDA approval because you're like, this is not FDA approved. I'm going to talk about that. But if a medication like has not been approved for anything, then that to me is experimental. Once something has been approved for a use, I don't consider it experimental anymore. I think what is being said here is that some of what was mentioned, there's different data on its effectiveness and its use. But we have medications we use that continue to have research coming out. And since I've been using Ozempic, let's continue to use Ozempic because it's something that a lot of people know about. Ozempic for weight loss has some research to show, yes, it helps people lose weight. However, it's not effective at keeping it off. That most people, if they're using Ozempic for weight loss, not for diabetes, but for weight loss, that once they stop using Ozempic, the weight comes back. So, does that mean it's experimental now that with more research is coming out and we're kind of seeing that, it's really effective for many people, but for some people, not so good? Does that make it experimental? What makes it experimental? Because in the medical world, I do not consider these treatments that have been used in even the protocol, so meaning how we use the medicine. It has been about 17 years. I don't find that experimental. So I'd love us to define experimental because we are all talking different languages. We're using a lot of these words like new and experimental without defining them. The other argument used is that it was irreversible. So again, we're talking about two different medications. Puberty blockers is not irreversible. Puberty blockers puts a pause on puberty. You remove the puberty blocker and the endogenous puberty will resume. So puberty blockers are not irreversible. So what is irreversible are some of the changes that can occur with estrogen and testosterone. Those can be irreversible. And if you don't use estrogen, testosterone, your body has it just at maybe different ratios and different levels, you will go through a puberty that have irreversible changes. So whether you go through endogenous puberty or whether you use estrogen, testosterone, there are irreversible changes that will occur and have an effect on the patient. I'm going to dive into this just a little bit more in a bit, but it's going to be associated with the next couple of things too. Infertility was something else mentioned, that some of these treatments, specifically the estrogen testosterone, can lead to infertility. This was brought up in the Supreme Court case. There are other medical treatments in this age group that can cause infertility. The first one that comes to my mind are cancer treatments, and they can cause infertility. And so typically what has happened is the counseling of that and as well as discussing what the options are. But we don't use that as a reason, even in this age group, to not allow for a medical treatment. And then the last thing that was mentioned, I'm going to use the term retransition. What the term often used in the case was detransition, meaning that somebody who has transitioned to an identity different than what they were assigned at birth, if that person identifies as what they were assigned at birth, that's what people mean by detransition. I use the term retransition because you can't undo what has been done. That person has lived their life with that experience, and then they retransition, meaning they transition again. Now, there are a few things I want to say about this when it was discussed. They used retransition and regret rates interchangeably, but they're not interchangeable if you look at the literature. There are individuals that will retransition that do not have regret. So just because somebody retransitions does not necessarily mean regret. The other part about that is those rates are extremely low for retransition. we're talking about like 2%, 2.5%, I think, on the study that is one of the best, but it's a low number. As Justice Sotomayor mentioned in the case, there are a lot of medical treatments that have a regret rate. And again, retransition regret is being used interchangeably there. But that is true. There are a lot of parts of medicine where we have to make a decision, and no treatment is going to be perfect, whether it means it doesn't work, whether it has a negative effect, whether people wish they had never undergone that. There are, as far as I wish I had never done that, there are numbers for that in knee surgeries, in gastric bypass surgeries, and all of them are much higher than this. So retransition rate was the other thing that was often. And the other point I would like to make on that is that sometimes you have to look at when you look at retransition rates in research, you have to read exactly how they define that because many times, if you read carefully, somebody may retransition, but not to the identity for which they were assigned at birth. They may retransition to a different identity, meaning if somebody was assigned male at birth, they may have transitioned to live their life as a woman, and then they may retransition and live their life as non binary. So there are things that are really important to understand when we're looking at retransition rates. Often in the research literature, sometimes the term desistance is also the other term used. But this is my thing. First off, retransition regret are not always necessarily the same thing. And second, we're talking about extremely low numbers that are much lower than a lot of aspects of medicine. But the bigger issue with these last 3 points, the irreversibility, the infertility, and the retransition, that the case that was made is many times in medicine, when we have concerns like these, we put regulations into effect. So we don't say nobody can have this treatment. We put regulations to try to prevent some of these things as much as we can. For example, you may make a regulation that there's certain counseling that has to occur. The legislature has definitely put regulations on certain medical treatments that certain things have to be mentioned in that counseling before a person can sign and do whatever treatment. So, one of the points that the plaintiff was making, that the US was making, was that you're just getting rid of the entire treatment for everyone rather than allowing for regulations for some of these concerns. And that's not medical regulations. That's not the way we have ever treated any other concern in medicine from a legislative perspective. We haven't treated it by just getting rid of it for everyone when there is an effectiveness that I think we all can agree upon for a large percentage of the patients. The other part that was brought up that kind of went against this is not a typical way you handle medical concerns or create medical regulations. Medical regulations aren't all or none, like I mentioned. But the other concern was when these laws were placed, they were placed with the language that said that minors should be encouraged to appreciate the gender for which they were assigned. This goes against the science and the medicine of gender dysphoria. We don't ask other people to just appreciate how they were born or created rather than provide a treatment that we know is life saving. And I think a lot of these issues come up and were demonstrated by the defense by keep referring to gender dysphoria as a psychological issue. And this goes beyond psychology. In medicine, the things we treat, all of it has a psychological issue as well as a biological issue. And I would argue that gender dysphoria is no different. The last thing I want to talk about, which wasn't a really major part of the Supreme Court case, but it was mentioned, and it is definitely discussed in the appellate court decision. And that was the point that these medicines are not FDA approved for gender dysphoria. And the appellate court went so far as to say the FDA has decided not to approve this for this. So what does that tell you? What it tells me is the appellate court does not understand how the FDA works. That's what that tells me. Because the way the FDA works is when a medication is first introduced, it is based on a treatment, on a cause. So, for example, puberty blockers, certain GnRH agonists, were brought through the FDA for precocious puberty. That is what they were looked at. And so the FDA approves it for that. But once the FDA has approved it, a provider who has prescription rights can prescribe it for whatever reason they deem necessary. And that's what we call off label use. It is on label if you use it for what the FDA approved it for, but many medications are used off label. For example, in my OBGYN world, misoprostol is used frequently. The FDA approval of misoprostol is for gastric ulcers. It's a GI medication, but it has been found to be very effective for cervical ripening and for postpartum hemorrhage, just to name a few things. And so we use it for those things, even though that is off label use. It has been shown to be effective for those things. Just to have all reproductive systems equally represented here, metformin. Metformin is approved for diabetes, yet it's used for prostate cancer off label. So we have lots of medications that we use off label that have been proven effective for those things. The reason is the FDA doesn't go around going, "What are you using it for? Let me approve it." That's not the way it works. The drug company that makes that medication must take it back to the FDA if they want on-label use. So if they want misoprostol to be an on-label use, to be able to say that the FDA approves it for cervical ripening, for example, then they have to take it back and the company has to pay for that. That is going to be a very expensive endeavor that is not going to pay off. Because the only thing that the FDA approval, once that medication has been approved in some usage, the only benefit of bringing a medication back to get the FDA approval for a different use is that you can advertise it as such. So if there is a benefit to advertising your medication for a different use, then that would be a good reason to bring it back. But if it's not, and research can be done on it to use it in other ways, and physicians may know that and they may use it in those ways. So, an example I used earlier, Ozempic was originally a diabetic medication and it was approved in 2017. But in 2021, the company brought it back to get it on label use for weight loss. Why? Because once they got it FDA approved for weight loss, then they could advertise it. And I'm sure we have all seen the benefit of advertising Ozempic as a weight loss medication. It makes sense why they would spend the money to do that, to be able to advertise in that way. But just to be clear, the appellate courts said, well, something must be wrong with it if the FDA hasn't approved it for this use. And I just want to point out that is inaccurate. The FDA does not go around deciding what to approve. It is brought to them. Once a medication has been approved for any use, a prescriber can prescribe it for whatever use they deem necessary. And of course, we try to do it based on research and the standards of care. Many medications that are used off label. Even as I mentioned earlier, for ulcerative colitis, that medication that was originally to prevent organ rejection can be used for ulcerative colitis to prevent flare ups, and that is an off label use. So I'm hoping that through this medical perspective, you can see that the big issue here has been definitions. The first concern of a difference in diagnoses. Defining what is important in that. Is it the difference in diagnoses? Because we treat things the same that have different diagnoses all the time. Is it how it works? Is it what it's used for? It's really being clear on that. And then the concerns for medical treatment, looking at those definitions. What's it mean to be experimental? What does it mean to be new? And also defining medical regulations are typically putting regulations that don't eliminate that treatment for every single patient, but making regulations to address those specific concerns so that patients can get the treatment that is supported by multiple medical associations, and creating the regulations to be more discerning to discuss those concerns. And finally, the definition of the FDA and how it works. defining that how an FDA approves something, what it means to be off label, what it means to be on label, understanding that is important because at the end of the day, definitions matter.